Thank you for having me. I have to just give everybody a heads up, like I actually have COVID, and so I'm hoping I can make it through the whole hour without coughing and losing my voice. So I've got tea, I've got cough drops, but bear with me if I have to take a few minute break here and there. So thanks for joining me. I'm talking today about the diagnosis and multimodal management of lumbosacral disease. As Susan said, I am an assistant professor at Ohio State, or the Ohio State. I get in trouble either way I say it. So, but some disclosures, some companies that I do consulting for, some of the companies that fund some of my research. Obviously, this talk is sponsored by Zomedica, so thank you for sponsoring this webinar for everybody. So objectives for this evening are to kind of review the anatomy and pathophysiology of lumbosacral disease, and then kind of review the common clinical signs associated with lumbosacral disease. We'll talk a little bit about comparing diagnostic options, and then primarily talking about the multimodal management options for lumbosacral disease. So epidural steroid injections, laser, acupuncture, TENS, shockwave therapy, and then exercise therapy. So lumbosacral pain is the leading cause of morbidity and early retirement in working dogs. Only about 40% of military working dogs actually reach planned retirement. So usually planned retirement is about 8 years, but most of the time these dogs are only reaching about 6.6 years before they're having to be retired. And considering each of these dogs, typical purchasing and training costs are about $40,000. And that's a pretty significant financial impact for the government. The United States actually spends about $7 to $8 million a year on about 1,000 to 2,000 military working dogs around the world. So lumbosacral pain is a pretty significant deal for these dogs. And then on the kind of other side of things, the sporting dogs, the lumbosacral disease is one of the most common reported injuries or conditions in agility dogs. So about 17% of injured dogs reported some sort of lumbosacral condition. Now, thinking about low back pain kind of more in general, there are multiple kind of underlying pathologies to low back pain in dogs. So degenerative lumbosacral stenosis is a big differential, intervertebral disc degeneration, sacroiliac degenerative joint disease, or even like SI-OCD, and then foraminal stenosis, so narrowing of the foramina. Now, each of these can happen individually. They can also kind of happen in combination. And we'll talk a little bit more about kind of the underlying pathophysiology of this later. So degenerative lumbosacral stenosis is one of the more common conditions that we see in the lumbosacral region. It is most commonly large breed dogs, middle-aged to older, and they typically have a male predilection, usually about 1.7 to 1 ratio in studies. We know that German Shepherd dogs are predisposed, but it's also really common in Labrador Retrievers. And Labrador Retrievers, there have actually been genetics that have been found to be associated with lumbosacral stenosis. I personally am also seeing it a lot more in Border Collies. So whether that is a genetic component in that breed or has more to do with what they're putting their bodies through doing agility, I'm not really sure. I am seeing it in particular lines of Border Collies, so I think that there probably is a genetic component in that breed as well. The interesting thing when we're talking about military working dogs is that even though it's very common in German Shepherds, Belgian Malinois that are also a very popular breed for working dogs in the US, they develop lumbosacral stenosis at a lower incidence than German Shepherds. So once again, kind of a genetic factor, as opposed to just purely the work that they're doing. So the lumbosacral joint is actually pretty interesting. because it's the most mobile functional spinal unit in dogs. There have been a variety of studies looking at trying to figure out what exactly the degree of mobility is, but kind of the studies range from somewhere between 27 to 37 degrees, which is pretty high. And so kind of on that the top images is the lumbosacral space in flexion, and then the lumbosacral space in extension. And you can see that that extension is pretty dramatic at that space. And so we're going to review a little bit of the anatomy, because this comes into play when we're talking about treatment, especially with regards to strength exercises. And so you have passive stabilization and active stabilization. The passive stabilization are the vertebral bodies themselves, the intervertebral discs, longitudinal ligaments, that ligamentum flavum, and then the articular processes, including those joint capsules of those articular processes. And then you have the active stabilization. So this is what we're targeting with our exercises. So you have your apaxial and hypaxial paravertebral muscles, and they coordinate activity kind of through that proprioceptive input. And it's augmented by the abdominal musculature. And then you can see just some more photos here of all of those kind of active stabilizing muscles. So the multifidus is a big one that we target during our exercise therapy. And so with regards to the pathophysiology of degenerative lumbosacral stenosis, we know that what happens is there's a compression of the cauda equina and the 7th lumbar nerve roots. Now, this is a multifactorial process. So it can involve type 2 degeneration and protrusion of that L7-S1 intervertebral disc. You can have subluxation or inflammation at the facet joints. You can have thickening of that joint capsule. You can have hypertrophy of the interarcuate ligament. And then you can also have a number of other processes. So you can have OCD lesions in L7 or S1. We occasionally see OCD lesions in the SI joints. We can see transitional vertebral anomalies, sacralization of L7, S1. And so there are a number of kind of underlying pathologies that can be a component of this degenerative lumbosacral stenosis. Basically anything that kind of changes the biomechanics of that space increases the risk of developing lumbosacral stenosis. And then what happens is you get this impingement of the nerve roots and the vasculature of both the cauda equina and that L7 nerve root, and you get neuropathic pain. And so you can see in this photo on the left, you have kind of your normal L7 nerve root. And then on the right, you have this, photo of kind of this degenerative lumbosacral stenosis. So you have changes to the facet joints, causes that nerve root impingement. You get enlargement of that nerve root. And then there's a nice anatomy photo here, a dissection with your normal L7 nerve root on the left-hand side and the enlarged nerve root on the right-hand side. And so what causes this exactly? And that we really don't know. We know obviously there's some genetic components, obviously in the cases that have transitional vertebra or, obvious changes to their anatomy, OCD lesions. Those are a little bit more obvious, for the reasons why they develop this. But there are plenty of dogs that have visibly normal spines that still develop degenerative lumbosacral stenosis. And so there's the thought that there's potentially an increased or altered mechanical load on that lumbosacral disc that contributes to the high prevalence of disc degeneration at that space. Obviously, that comes into play with how much motion there is in the joint. And then if we think about the type of work that the dogs are doing that develop this most commonly, the military working dogs, that are scaling walls, the agility dogs that are doing a lot of jumping and extension, and disc dogs that you can see in this photo, a extreme amount of extension in that LS region. So is there, a component of this kind of repetitive increased mechanical load that's causing degeneration at this space? So what are the clinical signs? Depends a little bit on the case and how kind of severe it is. In the agility dogs or even the working dogs, the signs can be pretty subtle. And so sometimes it's just a little bit of an unwillingness to jump. In the agility dogs, we often see knocking bars. So when they're trying to clear the jump, they'll actually hit the bar and knock it. Stutter stepping, which is where instead of kind of approaching the jump and taking a clear jump, they hesitate a little bit. So they take an extra step or two before the jump. So they're kind of hesitating and measuring that jump and kind of thinking about having to get over it. Reluctance to sit, hesitancy to go upstairs. Sometimes they have a hunched stance. So they'll have kind of a pelvic tilt. And then the one thing that I find pretty consistently is this kind of lumbar apaxial muscle fasciculation. And I actually have a video of that in a little bit. And so here's a photo or a video of an agility dog that has degenerative lumbosacral stenosis. So you can see when he goes to jump, instead of jumping in extension, he kind of pulls his legs up underneath him and kind of heaves himself up over top of it. And so he's got a really abnormal jumping style. So when he goes to take off here, he starts to extend his low back and then he's like, oh, ouch. And then he pulls his knees up underneath him. He knocks that bar down. And then he goes to take this jump. Same sort of thing. He actually stays in extension most of the way through that one. That one's a little bit hard to see, but he'll come back around to this one. So there he takes off and then he pulls his rear legs up underneath him and kind of heaves himself over it. And I would say that particular jumping style is fairly classic for lumbosacral disease. It's not 100%, but it's pretty close. Whenever I see that, then that's one of my first top differentials. So this is a dog that also has lumbosacral disease. And you can see just her difficulty rising. And some of that, has to do with that mobility of that LS space. So you can see how she keeps her lumbar spine in flexion when she stands. So she really does not want to extend her LS. So she's really keeping her legs tucked underneath her and kind of pushing up just to remove that force on that LS. So this is the lumbar muscle fasciculation that I see a lot in these cases. And so you can see kind of that twitching when they move in certain ways. So often kind of when they get a little bit of extension of that spine, they'll get almost kind of a spasm of that lumbar musculature. And I have never seen anything about it in the literature. My hypothesis is that it's compensatory, that the muscles are trying to counteract that, lumbosacral kind of instability or excessive movement or impingement. So they're getting that kind of spasm. And a lot of times that will actually decrease or go away completely with treatment. Play that again. Other clinical signs, pelvic limb lameness or weakness. This pelvic limb lameness can be unilateral or bilateral. It may lessen or worsen with exercise, so that can be fairly inconsistent. Sometimes the lameness can be mild and intermittent. Sometimes it can be pretty severe, like non-weight bearing lameness, depending on the degree of nerve compression. A lot of these dogs also have concurrent iliopsoas pain or iliopsoas strains. I find that lumbosacral disease is one of the most common underlying pathologies for dogs that have iliopsoas strains, especially recurrent iliopsoas strains and iliopsoas pain. And if you think about the anatomy and the function of that iliopsoas muscle, it's a stabilizer of that lumbar spine. So if they are compensating for lumbosacral pain or instability in that area, that iliopsoas essentially has to work harder to stabilize that low back. And they will often get compensatory pain or even potentially tendinopathies with that. Neurologic deficits depends a little bit on the severity. They can have proprioceptive deficits. They can have motor weakness kind of with that distribution of that sciatic nerve. And then in the really severe cases, they can have fecal and urinary incontinence. That, those are the pretty severe cases. Most of the cases that I see in my sports medicine practice are much milder than the cases that our neurology sees on their service. So most of my sporting dogs are having kind of mild performance issues, maybe an intermittent lameness or a change in their gait, or things like iliopsoas pain, whereas the ones that see the neurology service tend to have more proprioceptive deficits, weakness. So there is kind of a range, and especially kind of depending on the cases that you're seeing. And so here is that same dog that had trouble kind of getting up. She is fully non-weight bearing on that left pelvic limb. So when mom sent me that video, I was like, oh, she tore a cruciate. Nope. She had LS disease. Other signs that we can potentially see are behavior problems. So aggression and anxiety are two behavior issues that we will commonly see in dogs with lumbosacral pain. And there was actually this study that looked at behavior problems in military working dogs associated with multi-level LS stenosis. And so these dogs had some of those clinical signs that we talked about earlier. So the reluctance to jump, but they also often had these sudden onset of aggressive behaviors, increased anxiety. Some of them had kind of self-mutilation of low back region, tail or hind legs. So kind of associated with that, neuropathy and the nerve pain. So diagnosis-wise, I typically do kind of 4 separate tests when I'm evaluating for LS pain. So LS junction pressure, so that is dorsal pressure. And then I will hyperextend that LS junction. Then I'll palpate kind of down the sciatic. And then I'll also do rectal palpation with dorsal pressure. So here's kind of that dorsal LS pressure, kind of right at that LS space. And she says, ouch, don't do that. So she doesn't mind the rest of her lumbar spine. But then getting to that LS space, she definitely reacts there. And then, I can't remember, palpating along the sciatic. She says she doesn't like that either. So I'm not digging into the sciatic in these cases. Obviously, like you shove your fingers into the sciatic nerve and they're going to react. I'm very kind of gently palpating along where that sciatic nerve runs. And these dogs that have this kind of radiculopathy and this, neuropathic pain are extraordinarily sensitive to that palpation. So it's barely even a light touch kind of along that area. So what do we do for diagnosis? Obviously, radiographs are a good place to start. Not helpful that, not that helpful for lumbosacral disease itself, but, ruling out other pathologies, ruling out, hip disease, stifle disease. Sometimes we'll see things like the transitional lumbar vertebra, or, changes that may, give us an indication that there's something going on in that LS space, but not a definitive diagnosis. So then we also have the option of advanced diagnostics like CT and MRI. The problem comes with the fact that neither CT or MRI correlate well with what's found in surgery. And then dogs without any clinical signs of disease might have imaging findings consistent with degenerative lumbosacral stenosis on advanced imaging. Then there's also the fact that the degree of that compression on imaging doesn't correlate with the severity or the prognosis. And then some dogs that have subtle or inapparent clinical signs may have degenerative lumbosacral stenosis, but the signs are only elicitable on palpation and their imaging can be normal. So it's a little bit hit or miss. We still usually recommend the imaging, but I always have the talk with the owner that even though they have clinical signs, we may not find anything. And then I also have to have the talk mostly with my sporting and working dogs is that the severity on imaging doesn't necessarily give us an idea of what the prognosis is. So some dogs that have pretty severe compression and you see their MRI and you're like, ooh, rehab great and go back to work. Others have really mild signs on or changes on MRI and you're like, oh, that's not so bad. You rehab them and rehab them and rehab them. As soon as they go back to activity, they have severe pain again and they end up having to be retired. So unfortunately, the imaging is helpful in the diagnosis, but not necessarily that helpful in determining prognosis. So once again, radiographs, helpful to rule out things like neoplasia, discospondylitis, vertebral anomalies, lumbosacral transitional vertebral anomalies, and congenital deformities are pretty prevalent in German Shepherd dogs. Depending on the study, they range anywhere between 3.5% to 29% in German Shepherds, probably depending somewhat on the gene pool. And then obviously these dogs that have transitional vertebra have a higher risk of developing degenerative lumbosacral stenosis. This particular dog was one that it was actually the border collie that had the abnormal jumping style. We usually do screening radiographs just to make sure that there's nothing crazy going on. And this dog actually had sacralization of L7, S1. So kind of fusion of that L7, S1. So that would explain why he ended up developing degenerative lumbosacral stenosis, because that area was completely fused. And then this particular dog, it was a 3-year-old border collie with trouble jumping. And when we did radiographs, we found that the dog had transitional T13 and 8 lumbar type vertebra. So once again, changes in the biomechanics. And you can see in this case, just the degree of that spondylosis change at that L7, S1 space, considering the dog's 3. So obviously a lot of, abnormal pressure on that space. So imaging wise, CT is more valuable for assessment of the osseous boundaries. The dogs that have degenerative lumbosacral stenosis typically have some changes kind of in the soft tissue opacity, but mainly we can see kind of the thickening of the articular processes, osteophytosis, so those kind of bony changes. There is typically good agreement between MRI and CT. In these cases, there have been studies that show that CT and MRI agree pretty well. One thing for both CT and MRI that I really want to stress to people is the need to have a dynamic imaging study. And so in the cases that come in, typically through our neurology service, the ones that have more severe clinical signs, typically a neutral scan is enough to get a diagnosis. The problem becomes our kind of sporting and working dogs that have these mild or intermittent signs. A lot of times the neutral positioning imaging can be completely normal. And what happens is these are more kind of dynamic impingement cases. So the dogs, while they're working, while they're doing agility, so they're jumping, their backs are in either significant flexion or significant extension, they're having this compression of the spinal cord at that L7, S1. And so when you scan them in just neutral, you may not find anything. And so what we do is we actually do 3 separate scans. We position them in extension, we position them in flexion, and we also do a neutral scan. And so this, a lot of times, will give us a lot more information about what that spine looks like in kind of this dynamic aspect, especially for these dogs that are doing a lot of activity. And it can be pretty dramatic where you have a completely normal looking spinal cord on neutral and you put them in extension or flexion and they have very significant compression. And that little cattle dog, the one who I had a couple of videos of, she was one that was like that when I was in private practice, I did not have an MRI. So I sent her to a local practice for an MRI. They just did neutral, said everything was completely normal. And I was like, gosh, I really feel like there's something going on there. And so I pushed to get her back in for a dynamic. And sure enough, it was really significant dynamically. And so I now make sure that all of my cases are getting dynamic imaging. Our service is really good. Our neurology and MRI service is really good about doing them, but it's something that if you're in practice and you suspect that this might be something that's going on, and most of you probably don't have access to MRI and you're referring out for MRI, make sure that this is on their radar, that there needs to be a dynamic study, because it just really sucks to get a neutral, have them spend the money for a full MRI neutral scan and not get an answer when you could have had an answer with a dynamic study. So what about management? So non-surgical versus surgical management. This study that this was based on is a little bit older now, but non-surgical management had improvement in about 50% of cases. Surgical management had improvement in like 67 to 97% of cases, and then about 10 to 30% failed to improve regardless of the treatment. So what does conservative management look like? Pharmaceuticals, so things like NSAIDs. Our neurology service goes back and forth about using NSAIDs versus prednisone in these cases. Sometimes they'll pick one, sometimes they'll pick another, sometimes they'll start with one and swap out to the other. Gabapentin, amantadine if they're really painful. Then there are epidural steroid injections, which we utilize quite a bit. TENS, which is transcutaneous electrical nerve stimulation, laser therapy, acupuncture. Shockwave, and then kind of the big one is kind of exercise management, which is, you know, primarily focused on kind of this core stability. Epidural steroid injections, typically what we're using is Depo-Medrol. The dose is 1 mg per kg with a minimum volume of 0.5 mils. Typically, repeated injections have gained favor after kind of an initial report of reduced clinical signs in about 79% of cases. About 20 dogs out of the 38 had no signs at a follow-up of 48 months. So typically we are planning on doing repeated injections as opposed to a single one, but there are also studies looking at single injections as well. The epidural steroid injections are typically safe. Obviously, you have risk factors associated with any sort of epidural injection, but overall fairly safe. It's a targeted therapy, so you can use a higher local dose with fewer systemic side effects. Some dogs will have kind of a transient like PUPD or some systemic side effects after injection, but it's typically fairly transient. Now, how long does the effect last? Depends a little bit on the study, whether you're using a single dose or doing kind of multiple doses for a more prolonged effect. So this study looked at a single dose. They found that after a single epidural steroid injection, there was improvement in 84% of dogs, but about 77% relapsed within 6 months. 15% failed to respond, and then another 15% had persistent resolution of clinical signs at a mean about 9 months. So if we do single injections, we usually plan on them lasting about 6 months, but sometimes if we do repeated, we can get longer than that. Other therapies, photobiomodulation therapy or laser therapy, which is the use of red or near infrared light to stimulate healing, provide analgesia, and reduce inflammation. Mechanism of action is that photons are absorbed by the chromophores and respiratory chain enzymes, which causes cell signaling and cascade of reactions. So nitric oxide disassociates from cytochrome C oxidase, and then kind of this whole downstream effect with changes in cyclic AMP, nitric oxide, calcium, transcription factors. So all of this affects kind of that inflammatory pathways and stimulates healing. And so we know that it also kind of stimulates mesenchymal cell production, collagen synthesis, collagen organization, and then decreases pro-inflammatory cytokines. Now, we don't have any studies in dogs using laser for low back pain, but I guess, maybe not good thing in people, probably isn't actually that good for humans, is that low back pain is a significant cause of morbidity in humans. And I can't even remember what the national annual cost of low back pain is for the healthcare system, but it's something astronomical. So there's a lot of research that goes into treating low back pain on the human side, especially with regards to a lot of these kind of alternative or kind of complementary therapies like laser and shockwave and electrical nerve stimulation and things like that. And so there have been positive studies on the human side looking at laser for back pain. And so extrapolating from the human studies, it's very possible that laser has a similar effect in our canine patients. We just need some studies to actually support that, but I use it in my patients just based on the human studies. Acupuncture can be a whole lecture in and of itself, but has local, segmental, and central effects, and has kind of a whole cascade of effects on the pain signaling and inflammatory pathways. Quite complicated when you get into it. And once again, a lot of studies on the human side, because low back pain is a problem and people like, trying things that aren't as invasive as, some of the kind of traditional, embedded nerve stimulators and things like that that they use on the human side. And so there have been some, pretty large systematic reviews and meta-analyses and on the human side that show, positive effects of acupuncture for patients with chronic low back pain. So I definitely use it in my veterinary patients as well. TENS is transcutaneous electrical nerve stimulation. This activates large diameter afferent fibers and activates kind of the descending systems to reduce hyperalgesia. The nice thing about these little units is they're relatively inexpensive. You can get them on Amazon for like 35 bucks. And so a lot of times, especially in the really painful patients, I will have the owners purchase them on Amazon, and then I will shave the spots for the pads because unfortunately, unless they're a really, really short-coated dog, the pads won't stick to the skin. And so I shave the spots for the owners to stick the pads on, teach them how to use it at home, and then they have that option to use at home. Shockwave therapy. Shockwave is a focused high velocity sound wave. They're high amplitude pressures with a kind of a short buildup time and then an exponential decay followed by this kind of negative pressure. Now, it's important to note that shockwave differs from ultrasound waves. Shockwaves have a lower frequency, they have minimal tissue absorption, and they have a lack of thermal effect. Whereas the goal of ultrasound, or at least therapeutic ultrasound, is primarily based on that tissue heating and increasing extensibility. So there are 3 types of focused shockwave units. There's electrohydraulic, there's piezoelectric, and electromagnetic. Radial shockwave, even though it's called shockwave, is not actually a focused shockwave. It's more of a pneumatic mechanical concussion, so not true shockwave. The electrohydraulic, so the PulseVet unit, has the most research behind it. The thing to remember when you're looking at studies and comparing protocols is that because these different shockwave units have different energies and properties, the protocols are not equivalent or comparable. So you can't take a protocol from one machine and assume it's going to be effective or use it for the other machines. So shockwave, you have the physical shockwave, you have that immediate biologic response, you get a release of cytokines, growth factor, and bone morphogenic protein, which then stimulates bone regeneration and healing, increases capillary density to allow for healing, and then, affects that kind of inflammatory response. We know that it protects chondrocytes, disintegrates calcifications, and then recruits stem cells to treatment site, which are not as big of a deal for the lumbosacral cases. We use shockwave for all of our tendinopathies. We use it for OA. But, for the low back pain, we're looking more for that kind of anti-inflammatory and analgesic effect. So once again, no studies in dogs, but there are studies in both people and in horses. So the studies in people are more for like SI joint pain as opposed to lumbosacral disease, but similar area. We know that it helps with the pain in those locations. And then this nice equine study showed that the shockwave raised the mechanical nociceptive threshold in horses with TL pain. So once again, not same space, but does help with, improving pain management in these cases. So we are actually doing a study on shockwave for lumbosacral pain in dogs. We are still enrolling patients in case anybody is semi-local to Ohio or have owners that are willing to drive. We are primarily looking for dogs with lumbosacral pain, not necessarily a definitive diagnosis of degenerative lumbosacral stenosis. So they do not need to have an MRI, but we're doing radiographs to rule out some of the other things like discospondylitis and neoplasia. They're getting 3 Shockwave treatments 2 weeks apart. And then we're doing gait analysis with a pressure sensitive walkway, von Frey anesthesiometry, and then CVPI. So hopefully we will be able to keep, fully enroll that study and have results out soon, but we still need patients. So if you guys have anybody, send them my way. So what about strength exercises? This is one of the key factors for treatment of low back pain in people, regardless of the underlying pathophysiology of the low back pain. And the kind of key component to this is this core stability. And so core stability is defined as the ability to control the position and motion of the trunk over the pelvis. And that allows for the optimum production, transfer, and control of force and motion to the terminal segment in these athletic activities. So back to kind of our anatomy review, for our epaxial muscles, you have your transversus spinalis, you have your longissimus, your iliocostalis, and your quadratus lumborum. So you've got all of these muscles that make up these epaxials. And then you have your hypaxials. So your iliopsoas, which we talked about, that often is overworked in the cases with lumbosacral disease. And then your abdominals, so your internal obliques, external obliques, and your rectus abdominis. And so in humans, low back pain, and this is generalized low back pain, so not things like disc disease or, a specific, pathology. They think that it's a problem of kind of this combination of lack of muscle strength, endurance, neuromuscular control, and then kind of diminished trunk or lower quadrant strength and endurance. So basically this whole muscular imbalance. And in humans, obviously a lot of us sit a lot. So there tends to be kind of this imbalance with your hamstrings, iliopsoas, piriformis, and tensor fascia lata that are overactive due to weak hip abductor, extensor, and core muscles because of our posture. So obviously this doesn't completely apply to our quadrupeds, but we do, see dogs that, have really poor posture, that have really weak muscle strength. I mean, even in some of the fairly fit dogs and athletic dogs, they maybe don't have as much muscle mass or strength or core, especially core musculature, as we would want them to have. And so this may not be as much of a component in our canine cases as it is in people, but for sure it is likely a component, and it's a modifiable component. So genetics, while you can, test for genes like in the Labradors, and you can, screen your breeding stock and do all of these things to address the genetic components of it, it's much harder to modify than doing things like strength exercises for these working and sporting dogs to support that low back, because it's possible that if you can get them super strong, you decrease some of that mechanical force on that LS space. And so kind of movement control impairment is this change of spinal alignment and movement pattern in a specific direction. And this is due to a change in joint motion accuracy caused by repetitive movements and long-term postures related to daily activities. Obviously, this is the definition in people. And so posture from sitting, or, people who do very specific movements, or athletes that, have a very specific movement pattern during their sport, are at a higher risk of developing this movement control impairment because of kind of this muscular imbalance. But we also do see this in our dogs as well. Dogs that are, you know, overusing their pelvic limb muscles and have really built up pelvic limb muscles, but are weaker in their forelimbs, or they are got these really bulky shoulders, but maybe, you know, don't have as much strength in their, you know, pelvic limb musculature. So we want, you know, muscular balance regardless of the patient. In humans, exercise therapy is the preferred way to manage low back pain. Core stability is kind of essential for that proper load balance within the pelvis, spine, kinetic chain, and core. And they've actually done studies in people that show that training frequency of 3 to 5 times per week with a training time of 20 to 30 minutes per session had the largest effect on pain and disability. Now, for most of our regular clients, asking them to do 20 to 30 minutes, 3 to 5 times per week with their dog is probably unrealistic. My agility people, my sporting dog and working dog people, no problem. Like if I would let them do more than that, they would do more than that. And I usually have to rein them in. But for our general population, I aim for like maximum of 10 minutes, you know, 3 to 4 times a week. I feel like most people can be fairly consistent about. Now you have some clients that just refuse to do anything, or they say they're like, oh yeah, we did some exercises maybe like 2 weeks ago once. So you've got a whole range of people, just like you do when you know, I'm sure you're physically, if any of you see physical therapists, they have lots of stories about all the people that are like, yeah, I do my exercises. Yeah, I do. And they definitely don't. And you can tell, because definitely the dogs that get their exercises have, you know, better outcomes and better progression. And so what we are looking for when we're doing our strength exercises is to try to encourage this kind of co-contraction of the trunk muscles to provide this stability. And we're really targeting kind of the multifidus and longissimus muscles. We're retraining the muscular balance, both kind of that dorsal ventral imbalance and that ipsilateral imbalance. And so some of the exercises that we use are posture work, weight shifting, 3-legged stands, diagonal leg lifts, stand down stands. So all of this kind of core stability work. And then we can make things harder by adding in instability equipment. And so posture work, what we're looking for is a kind of a square stance. And so we want kind of a perpendicular line from the antebrachium and the floor. And then same with the metatarsals. We want kind of the metatarsals perpendicular to the floor. And so this is actually much harder than it looks to try to get that appropriate posture. It actually requires a lot more core strength than people expect. And I compare it a lot to people holding planks. You know, it looks super easy, but then you're like looking at your watch and you're like, oh my gosh, this feels like a million years and it's been like 30 seconds. So it's not as easy to hold some of these positions as it looks. And he was quite fit before his surgery. And even he was having a hard time. And then you can make things harder. By adding instability equipment. So that's going to challenge those stabilizer muscles and those core muscles a lot more. The thing about exercises in dogs is that unlike in people where you can a little bit more specifically target certain muscle groups, most of the time we're doing kind of general body exercises and adjusting them in ways to get a little bit more targeting of specific muscle groups. But obviously the dogs can't do bicep curls. They can't do, you know, your, you know, hamstring curls and things like that to target those individual muscle groups like we can. And so we, you know, adjust our exercises to try to get that core stability, to, you know, shift weight forward and backwards to get more forelimb strengthening, pelvic limb strengthening, that type of thing. So this is just weight shifting. So that's an isometric exercise. So similar to kind of the plank and the posture work, where there's no flexion or extension of the joints. You're just holding your body in space, but still having to contract all of those stabilizer muscles. And then this is three-legged stand. So lifting up one leg and having them shift to the other three legs. And then you go around and you do that on each leg. And then obviously, you know, we would start this exercise on the floor and not on the instability equipment. So this is more of a progression, but going around and lifting up each leg individually changes the weight shift and that kind of muscle engagement a little bit different to engage those core muscles. And then these are kind of more like doggy kind of crunches. So you have them walk out and then you have them kind of walk back in and pull back. And that is a good exercise specifically for that multifidus. Also an exercise for the iliopsoas as well. So this is one I would not do right away. I actually don't do this exercise right away for my Ellis dogs. This is more of an advanced one where they're no longer painful. And for the dogs that no longer have iliopsoas pain either. And then diagonal leg lift is picking up one front leg and the opposite rear leg. And then we can increase the difficulty by adding in things like peanuts, box core work, which is similar to that kind of pull back exercise, except then they pull their front legs all the way up onto the box. So it kind of takes that core engagement to the next level. And then kind of reach and drive exercises, which is similar to kind of them reaching forward in that one exercise. So in this exercise, I'm having him kind of walk backwards and pull his feet up onto that platform. So as he pulls his feet up and then moves his rear feet backwards, that's a good core engagement. Also good for proprioception. And then once again, like everything else, we can make things more difficult. So adding in that instability equipment, having him lift his front feet so that engages that core musculature and those stabilizer muscles more. He says that's hard. And then one thing that I won't really talk about, but does have a whole place is surgical management. I'm not a surgeon, so I'm not qualified to actually talk about this, but there are a number of surgical techniques to address lumbosacral disease. Depends on what exactly is going on in that space, whether there's static or dynamic compression, whether there's foraminal stenosis. So this is something that our neurosurgeons have to work through in these cases. Most of the time, they will not take the dogs to surgery unless they either have really severe clinical signs or we just cannot manage their discomfort or their signs with rehab and conservative management. Bunch of papers on surgical techniques, if anybody is interested in reading about surgeries.